the moment is chaotic. It could be a highway collision, a fall, or a severe accident at home. In those first few seconds, there is one threat, one silent, insidious killer that is operating faster than any responder can move.
Uncontrolled blood loss.
Severe hemorrhage, and the inevitable progression toward shock. We are talking about the ultimate race against time, where the ticking clock isn't measured in minutes, but in liters of life-sustaining fluid.
And that extreme urgency is really the focus of our deep dive today. We've gone through a whole stack of source material from emergency medical protocols to, cutting-edge trauma research to understand exactly how the body reacts to acute blood loss.
Where its own defenses fail.
And, crucially, the life-saving protocols that are designed to buy that precious time. Our mission, really, is to transform some pretty complex, critical medical knowledge into something digestible and deeply impactful for you.
Okay, let's unpack this immediately, because there has been a real paradigm shift in trauma care that listeners need to know about. For decades, the mantra, the unshakable gospel, was airway, breathing, circulation, ABC.
Right. It was drilled into everyone.
But when severe, life-threatening hemorrhage is on the table, that entire sequence is it's jettisoned.
That's the core of modern trauma management. The old rule, ABC, is often now replaced by CAB.
Circulation, airway, breathing.
Exactly. The immediate focus shifts from ensuring air intake to, securing the blood flow, stopping the leak.
Why this radical reordering, though? It seems so counterintuitive. Doesn't the patient need to breathe first?
They do, eventually. But the physiology itself dictates the priority. When massive bleeding is happening, the true limiting factor isn't the availability of oxygen.
It's the delivery system.
It's the delivery system, the circulation. Look, if you spend 60 vital seconds securing an advanced airway to, let's say, intubating the patient, but they're actively exsanguinating.
You've just wasted those 60 seconds.
You've completely wasted them. Because that meticulously delivered oxygen has no adequate circulation, no blood volume, and really no blood pressure to transport it to the critical tissues.
So the brain, the kidneys, the heart, they're still starving for oxygen.
Exactly. They require perfusion, which is just that flow of oxygenated blood. If the tank is nearly empty, or, if the pipes have a massive leak, you can fill the lungs with the purest oxygen in the world, and the patient will still enter irreversible shock.
So you have to stop the bleed first?
The bleeding must be stopped, or at least massively slowed, first. That is the revolutionary core of CAB. Bleeding is the fastest way to die, and therefore circulation control dictates the entire initial response.
That sets the stage perfectly. We are talking about hemorrhage, which is simply bleeding. But if we're going to be effective guides here, we need to show the listener the full spectrum of danger.
Right.
It's not just the dramatic arterial spurting you see in movies. Even a slow loss can be catastrophic.
Absolutely. Our sources really categorize hemorrhage into two buckets: the external visible threat and the internal invisible one. You can start with something that seems manageable, a cut that just won't stop, and some vague symptoms like general weakness or maybe dizziness.
Things you might even brush off at first.
Exactly. But if the body can't compensate, that seemingly minor external bleed can progress, and progress rapidly, even insidiously, toward life-threatening shock.
Let's focus on that visible threat first, then. External hemorrhage. What are the foundational and immediate methods of control that all responders are going to rely on?
Well, the first line of defense is always the most immediate and accessible thing you can do. Direct pressure.
Just push on it.
Just push on it, often supplemented by a thick pressure dressing. This works by compressing the injured vessel against whatever's underneath it, usually bone or tissue. However, when direct pressure fails, or the injury is just obviously catastrophic from the get-go, we have to escalate fast.
And that's when you move to more advanced interventions.
That's when we move to specialized interventions. Stabilizing the injury with splints, applying things called hemostatic agents, and deploying tourniquets.
We absolutely have to linger on the severity based on the type of vessel that's injured, because that flow pattern, it tells you instantaneously how much time you have left.
It's your immediate visual diagnostic tool. It really is. You have capillary bleeding, which is the least concerning in terms of, sheer volume loss, though any wound can become infected.
And that's like a scrape.
A scrape, yeah. It's dark red, it oozes slowly, and it usually clots on its own pretty quickly. Then you have venous bleeding. Venous blood is darker, more of a maroon color because it's deoxygenated.
Right, it's on its way back to the heart.
Exactly. And it flows steadily, like a slow river. While it can be significant, the pressure is lower, which makes it generally easier for the body's natural hemostasis system to manage.
And then the true alarm bell, arterial bleeding.
Arterial blood is a bright, highly oxygenated cherry red, and crucially, it spurts. It pumps rhythmically, right in time with the patient's heartbeat.
You can see the pulse in the bleeding.
You can see the pulse. If you witness this, you are in a maximum emergency situation. Our sources emphasize this horrifying fact. If a major artery is fully lacerated or torn, a person can exsanguinate. They can bleed out their entire circulating volume.
In how long?
In as little as 2 to 3 minutes.
Oh, wow. 2 minutes.
That's the entire reason for that 20-second CAB protocol shift we just talked about.
That's why everything we discuss about management has to be done with just brutal speed. But sometimes what you see on the outside, it can be misleading, right?
Absolutely. The severity of the external bleed can be incredibly deceptive. We often see situations where the mechanism of injury, the MOI, tells us more than the visual blood loss.
Give us an example.
Think about a traumatic amputation where massive force or friction like from a grinder or an industrial saw has been involved. The tissue destruction or the heat might actually effectively cauterize the ends of the smaller vessels.
So there's surprisingly little bleeding.
Surprisingly little immediate visible bleeding, yeah.
Yeah.
So a first responder might feel this false sense of security because they don't see blood everywhere.
And they might focus on other injuries.
Precisely. They might focus on other injuries when the primary long-term threat is internal contamination or, massive tissue damage. Conversely, consider a crush injury to the lower extremities, say someone's pinned by a heavy vehicle.
Okay.
They might have a closed or a complex open fracture, and while there might be some surface bleeding, the sheer internal damage to muscle, to deep tissue, and the major vessels means they are bleeding profusely inside the thigh or calf compartments.
So it's all happening under the skin.
We call this compartment syndrome waiting to happen, or just deep-seated hemorrhage. These situations often require immediate tourniquet application, even if the external wound looks relatively benign because the deep tissue is just shredded.
That shifts our focus perfectly to the invisible, insidious threat, internal hemorrhage. This is where diagnosis depends entirely on deduction, on the mechanism, and on these really subtle physiological cues.
Internal hemorrhage is the true silent killer because, well, you can't apply a pressure dressing or a tourniquet to it. It stems from trauma blunt force injuries to the chest, the abdomen, or the pelvis, long bone fractures, but also from non-traumatic conditions, which clinicians have to be equally alert to.
And what would those be?
The sources list some key non-traumatic examples like massive GI bleeding, which often goes undetected until the symptoms are really advanced. Ruptured ectopic pregnancies, which can cause rapid and potentially lethal abdominal bleeding in women.
And ruptured aneurysms.
Right, where a weakened blood vessel wall just suddenly gives way.
The challenge here, especially in that pre-hospital environment, is that the patient might just be complaining of generalized pain or discomfort, and they might look relatively okay, at least initially.
That's the danger. Signs of significant internal bleeding do not always develop quickly. You might have a large quantity of blood pooling in the abdomen or around the pelvis before the systemic blood pressure even starts to crash.
So what do you rely on?
Clinicians are trained to rely heavily on the mechanism of injury, the MOI, what happened to the patient. You combine that with subtle, specific physiological changes.
What are those specific subtle signs that would indicate massive internal volume loss?
The 3 physiological harbingers we look for are complaints of pain and tenderness over the injured region, the rapid development of tachycardia, an elevated heart rate, and pallor.
Pallor being?
Extreme paleness, yeah. It's especially noticeable in the mucous membranes or the nail beds. Tachycardia is the body's frantic, immediate attempt to compensate for falling blood pressure. The heart speeds up to try and circulate the remaining volume faster.
And the paleness is because the body is pulling blood away from the skin.
It's actively shunting blood away from the non-essential peripheral areas, the skin and extremities, to protect the vital organs, the brain, and the heart. The high index of suspicion for shock must be maintained continuously based on these initial subtle cues.
So tachycardia is the body firing its first alarm. But to truly understand the urgency, we need to quantify the danger. How much blood can an average human actually lose before those compensatory mechanisms start to fail?
Well, we first have to understand the baseline volume. For an average adult male, the total blood volume is roughly 70 milliliters of blood per kilogram of body weight. For adult females, it's a little less, closer to 65 milliliters per kilogram.
So for a typical, say, 70 kilograms or 154-pound adult, what are we talking about?
You're looking at approximately 5 liters of circulating blood.
Okay, so out of those 5 liters, what is the point of no return? What's the critical threshold?
The consensus, which is reinforced by trauma protocols worldwide, is that the body cannot tolerate an acute blood loss of more than 20% of its total circulating volume.
20%. That is a critical number. So in our 5-liter example, that means losing more than 1 liter, just over a quart of blood.
Losing more than 1 liter acutely, meaning in a very short time frame, will cause significant measurable changes in vital signs. That marks the crossing into clinical instability.
And the other critical point here is the scale, right?
Oh, absolutely, the scale. A 20% loss in a 5-liter adult is 1 liter. A 20% loss in a small child or an infant might be less than 200 milliliters,
That's about the size of a soda can.
a single soda can's worth. And that makes pediatric trauma management just exponentially more precarious and sensitive to even the smallest errors or delays.
So the moment the hemorrhage starts, the body goes into defense mode, trying desperately to stop the leak. And that defense mechanism is hemostasis, the clotting cascade.
That's our natural miracle system. Hemostasis is usually incredibly effective, and this is why venous and capillary bleeding is far more likely to clot spontaneously than arterial bleeding.
Just lower pressure.
The pressure is simply lower, allowing the clot to form and adhere. Under normal conditions, bleeding tends to stop on its own within about 10 minutes.
Okay, let's slow down here and give this biological process the attention it deserves. Let's walk through the 3 specific physiological steps of the hemostasis response, maybe using some analogies to make them sticky for the listener.
Perfect. The very first step, the immediate reflex, is vasoconstriction.
So the vessel tightens up.
Think of the injured vessel as a burst water pipe. The surrounding smooth muscle clamps down, immediately narrowing the diameter of the vessel right at the injury site. This acts like the body's emergency traffic regulator, dramatically reducing blood flow to the damaged area.
It buys time.
It buys precious time for the subsequent steps.
So that's the first defense, slowing the flow. What's the second step, the temporary plug?
That involves platelet aggregation. Platelets are these small, specialized cell fragments in the blood that get activated by contact with the damaged vessel lining.
And when they're activated, they get sticky.
They become sticky, yeah. They adhere to the injury site and to each other, and they rapidly form a temporary, soft plug. It's like putting wet chewing gum over a leak. This plug just mechanically blocks the hole.
But chewing gum isn't permanent. You need the biological equivalent of cement and scaffolding.
And that's the final and definitive step, which involves a plasma protein called fibrinogen. Through a really complex sequence of chemical reactions, the clotting cascade itself, fibrinogen, is converted into fibrin.
And fibrin is the strong stuff.
Fibrin is the strong stuff.
Yeah.
It then weaves itself through that platelet plug, forming a strong, durable, cross-linked mesh. This mesh acts as the biological scaffolding, or net, holding the clot together permanently and forming a stable seal, which definitively controls the bleeding until the vessel can heal properly.
And if that final fibrin matrix doesn't form robustly,
The plug will simply wash out under the pressure.
it's a beautifully efficient system, but in the trauma environment, it is so easily defeated. What are the major factors that overwhelm or override this natural clotting mechanism?
Medications, they're the prime disruptors in modern healthcare. Anticoagulants or blood thinners like warfarin or the newer oral anticoagulants, they are designed specifically to interfere with various factors in that clotting cascade,
Making it harder for that fibrin mesh to form.
making the blood less likely to form that final critical fibrin mesh. This means a seemingly minor injury can result in just relentless, uncontrollable bleeding.
And it's not just the dedicated thinners. Some common heart medications can knock out that initial vasoconstriction step.
That's right. Patients who are taking certain cardiac medications, particularly beta blockers, might find that their body's initial reflex response is dampened. Beta blockers reduce the heart rate and blood pressure, but they also interfere with the sympathetic nervous system's immediate ability to cause vasoconstriction.
So they prevent that traffic regulator from slowing the flow.
Exactly. And if the flow isn't slowed, the platelets struggle to aggregate and the nascent clot is just easily washed away.
Beyond chemistry, simple physics can defeat the system if the injury is just too big.
Exactly.
Hmm.
If the force of the blood coming out is too high, typically with a major arterial tear, or if the opening in the vessel is simply too extensive, the clot cannot physically block the hole. The blood pressure just overcomes the tensile strength of the forming clot.
And what if the vessel is only partially cut?
Well, if a vessel is only partially cut, The clean edges that are needed for smooth constriction might be compromised, preventing the vessel walls from sealing off, which forces continued, often rapid, blood loss until external pressure is finally applied.
And we can't forget hereditary conditions. These patients are living with a system that is fundamentally compromised right from the start.
We're talking about hemophilia, where one or more of the necessary clotting factors are genetically absent or deficient. There are different types, but the result is the same. Without those critical components, the body struggles or fails entirely to form that stable fibrin mesh.
So what's the takeaway for a responder?
The crucial point for any person responding to a situation involving a hemophiliac is that any injury, no matter how trivial it appears, even a deep bruise, is potentially a life-threatening internal hemorrhage. It demands immediate and serious medical attention, which often involves the administration of synthetic clotting factors.
So we've established the rapid danger of blood loss and where the body's own defenses fail. This failure leads us inevitably to the state of shock. And shock isn't just low blood pressure, is it?
No, not at all. Shock is fundamentally a state of inadequate tissue perfusion.
Meaning the cells aren't getting what they need.
The cells are not getting the oxygen and nutrients they need to survive. While hypovolemic shock, which is caused by inadequate blood volume, is what we're focused on today, shock can also stem from pump failure. That's cardiogenic shock or vessel failure or even respiratory failure.
But in trauma, it's almost always about blood loss.
Hemorrhagic shock, caused specifically by blood loss, is overwhelmingly the most common type encountered in acute trauma settings, as highlighted repeatedly in our sources.
When a patient is hemorrhaging catastrophically, where are the most likely and dangerous sources of that bleeding?
The body is full of potential bleeding spaces, but trauma is highly predictable in where it causes exsanguination. We look for sources due to blunt or penetrating injuries to major vascular structures, long bone fractures,
Like the femur.
particularly the femur, which can easily hide 1 to 1.5 liters of blood in the thigh alone, or pelvic fractures. The pelvis especially can leak massive amounts of blood into the retroperitoneum with very little external sign.
And if we look at penetrating injuries, stabbings, or gunshots, what organs carry the highest risk of immediate fatality?
Our sources clearly identify the organs and systems that are most likely to cause rapid exsanguination if they're penetrated. The heart, the major thoracic and abdominal vascular systems like the aorta and the vena cava,
The big pipes?
the big pipes, the large venous system, and the liver. The liver is incredibly vascular. A single laceration can turn the abdomen into a massive pool of blood very, very quickly.
To manage this progression and triage the patient effectively, we relied on the classification system from the American College of Surgeons Committee on Trauma. Let's use this to sort of map the patient's journey from minor loss to critical instability.
This system organizes hemorrhagic shock into 4 classes, and it tracks the progression from early compensation all the way to terminal failure. The first 2 stages are generally called compensated shock.
Meaning the body is managing, but just barely.
Exactly.
So tell us about compensated shock, classes 1 and 2. What is the body sacrificing to maintain that core perfusion?
Well, class 1 is minor blood loss, up to 15%, where the patient might only show minimal changes, maybe a slightly elevated heart rate and some anxiety. Class 2, however, is where the compensation really kicks in, losing 15% to 30% of their volume, up to 1.5 liters.
What's the key sign there?
The key sign here is sustained tachycardia, a heart rate over 100 beats per minute, and a narrowing pulse pressure. Now, the blood pressure might still look near normal, but that's an illusion.
The body is fighting back.
It's fighting back by dumping epinephrine and norepinephrine, constricting the peripheral vessels. This shunts blood away from the skin, the muscles, and the gut to protect the heart and brain.
So the normal blood pressure reading is actually hiding a frantic, unsustainable internal struggle.
Precisely. They might be slightly hypotensive, but their core vitals are maintained because of this extreme compensation. You will see those early subtle signs of poor perfusion: anxiety, cold extremities, prolonged capillary refill time.
Which is when you press on their nail bed.
Right, if you press on their nail bed, it takes longer than 2 seconds to return to pink. This is the stage where pre-hospital intervention has the absolute highest chance of success.
But if the bleeding continues, the compensatory mechanisms begin to fail, and we enter the territory of decompensated shock class 3.
Class 3 is defined by blood loss of 30% to 40%. That's up to 2 liters. At this point, the oxygen supply to the tissues is critically compromised and cellular metabolism is seriously altered. The patient is definitely hypotensive, often significantly so.
And their mental state.
Their mental status deteriorates. They become confused, agitated, or even obtunded due to a lack of adequate cerebral perfusion.
And the body is still trying to constrict vessels, but now it's sort of working against itself.
Yes, the compensatory mechanisms are now in hyperdrive, leading to a massive increase in systemic vascular resistance, or SVR.
Which is the resistance of the whole system.
It's the cumulative resistance of the entire peripheral circulation. Think of it as the degree to which all the capillaries and small arteries are clamped down. High SVR means the extremities are cold, clammy, mottled, and may be pulseless distally.
So it saves the core, but kills the periphery.
The problem is that while this high SVR keeps the blood in the core, it severely restricts oxygen flow to the peripheral tissues, accelerating the cellular damage and pushing the patient toward failure.
And class 4. That's the threshold where the prognosis becomes grim.
Class 4 is the terminal stage, representing a loss of over 40% of blood volume. The patient is profoundly hypotensive, confused, or unresponsive. Compensatory mechanisms have failed, tissue damage is widespread.
And without immediate, massive intervention.
If intervention is not successful and immediate, this progresses rapidly to death. Irreversible shock.
It's not just blood volume that kills them at this point, though. It's the lethal synergy of the body's failed response.
Let's talk about the horrific feedback loop known as the trauma triad of death. This is what turns a severe injury into a near-certain fatality.
This triad, hypothermia, coagulopathy, and acidosis, is a positive feedback loop that just accelerates mortality. It's like a biological death spiral, and if you don't attack all 3 points simultaneously, you lose the patient regardless of how much blood you replace.
Walk us through the start of the spiral. The hemorrhage causes a critical drop in core temperature.
That's hypothermia. Uncontrolled bleeding leads to inadequate circulation and energy generation, causing the body's core temperature to drop rapidly. This is why keeping trauma patients warm is absolutely non-negotiable.
And as the body gets colder,
The moment that core temperature drops, it drastically impairs the enzymes required for the clotting cascade. The body's coagulation mechanisms work optimally only at normal body temperature.
so getting cold causes the inability to clot. That's coagulopathy. Correct. The patient becomes chilled, the clotting mechanism fails, and they bleed even more freely. Increased bleeding leads to further hypoperfusion and faster chilling. But the loop gets even worse because of what happens at the cellular level when oxygen delivery is insufficient.
And that's where the cells shift to anaerobic metabolism, releasing acidic compounds. That's acidosis.
Yes. When cells don't get enough oxygen due to hypoperfusion, they start using anaerobic metabolism to create energy. This releases lactic acid and other acidic byproducts into the bloodstream, creating a severe metabolic acidosis.
And acidosis is the final deadly blow to the heart.
It is. Acidosis inhibits the heart muscle's ability to pump. The heart becomes less efficient, further reducing the overall cardiac output and oxygen delivery.
So it's a feedback loop. Bad heart performance means less oxygen, which means more acidosis.
And that lack of oxygenation and poor perfusion accelerates the systemic metabolic failure and reduces the body's ability to generate heat metabolically, driving the patient deeper into hypothermia, which in turn worsens the coagulopathy.
It just keeps feeding itself.
The three elements are intertwined, each one driving the other two to worsen the patient's condition. Our sources are explicit. Breaking this triad, warming the patient, correcting the clotting deficit, and fixing the acidosis is the absolute immediate goal of advanced trauma care.
That terrifying insight into the trauma triad shows why speed and comprehensive care are so paramount. Now we can shift to the immediate pre-hospital interventions aimed at stopping that initial bleed and preventing the spiral from ever beginning.
The foundational management philosophy is built on 5 pillars. Follow standard precautions, always maintain a high suspicion for shock, transport the patient rapidly to definitive care.
And provide aggressive management en route.
Aggressive management en route, and never forget the psychological support the patient desperately needs.
When it comes to external bleeding from an extremity, the single most impactful life-saving field intervention is the tourniquet. When is it indicated, and what defines its successful application?
The indication is severe, life-threatening hemorrhage from an extremity. So that means the injury is distal to the armpit or the groin. That cannot be controlled by direct pressure alone.
And success is all about speed.
Considering that 2-minute window for exsanguination from a major arterial tear, successful application is defined entirely by time. The consensus target, often cited in military and civilian trauma protocols, is that a commercial tourniquet must be applied, tightened, and secured in under 20 seconds.
20 seconds. That mandates simplicity and mechanical efficiency. We don't need to list every commercial brand, but what are the core mechanical principles that define these devices?
Well, the design principles all focus on achieving massive circumferential pressure very quickly. The most common feature is the windlass mechanism,
A little rod you twist.
a rigid rod used to twist the strap tightly, which provides significant leverage and mechanical advantage to occlude the arterial flow entirely. Other systems use a ratchet mechanism for incremental, precise tightening or thick, flexible material designed to be stretched and wrapped multiple times to provide the necessary broad compression.
The key is just stopping the flow completely.
The key is total occlusion of arterial flow, which is confirmed by the absence of a pulse distal to the device.
The technique for application is crucial for both effectiveness and patient safety. What are the non-negotiable precautions?
Several absolute rules apply. First, the tourniquet must be applied high and tight, proximal to the injury zone, so closer to the torso, but never directly over a joint.
Never on a knee or an elbow.
Ever. Joints do not provide the necessary rigid structure to compress the artery effectively. Second, use the widest bandage or material possible. You must absolutely never use narrow material like wire or rope or even a thin belt.
Why?
Narrow materials focus pressure in one small area, risking severe local nerve damage and cutting the skin without actually effectively occluding the deep artery.
And once it's on, the commitment is irreversible until surgical intervention.
That's correct. You must immediately document the time of application, and you must never cover the tourniquet with a bandage or clothing so medical staff can see it instantly.
And you never loosen it.
Crucially, the rule is to never loosen a tourniquet after application unless under specific medical direction, which is usually only in a controlled hospital setting. The risk is profound. Loosening it releases all that acidic, cold, partially clotted blood back into the central circulation.
Which would trigger the trauma triad.
It can immediately precipitate profound acidosis and coagulopathy, triggering that fatal trauma triad we just discussed.
Okay, that covers extremities. But what about the inevitable injuries in areas where a standard tourniquet simply cannot be applied? The groin, the armpit, the base of the neck.
Those are termed junctional hemorrhages. For these areas, inguinal or groin or axillary, the armpit, we utilize specialized junctional tourniquets.
And what do those look like?
These devices typically consist of a belt system that wraps around the torso or pelvis and incorporates a bladder or a compression pad that is inflated via a pump or a crank, applying direct pressure deep into the vessel junction.
That seems like a very high-tech way to solve a tough anatomical problem.
It is, and it solves another major trauma problem at the same time. Many junctional tourniquets, when they're applied around the hips and inflated, can serve a critical dual function as a pelvic immobilization device.
And pelvic fractures are a huge source of bleeding.
A huge source of internal bleeding, and stabilizing them is a major priority. This single device can help control hemorrhage and immobilize the fracture, saving crucial time.
Alongside direct pressure and tourniquets, we have specialized dressings, hemostatic agents, and wound packing. What makes these agents superior to standard gauze for severe bleeding?
Their purpose is to chemically enhance and accelerate the natural clot formation, which makes them vital for those junctional wounds or deep track wounds where direct pressure alone just isn't sufficient.
And how do they work?
They work through several sophisticated mechanisms. Some contain minerals that rapidly absorb water, which dehydrates the blood and concentrates the existing clotting factors. Others have proprietary chemicals that adhere strongly to the damaged tissue.
And some just kickstart the cascade.
A third category chemically stimulates the intrinsic clotting cascade, forcing the rapid conversion of fibrinogen to fibrin right at the wound site.
So instead of passively waiting for the body to clot, we are pouring in a catalyst. What characteristics define a truly effective field hemostatic agent?
Our sources emphasize several key attributes. They must be lightweight, extremely conformable to the wound shape, and robust enough to withstand the high pressure and flow of arterial bleeding. Critically, they have to cause minimal tissue damage, be easy for surgeons to remove later, and must not spread systemically.
And the most common form now is impregnated gauze.
The dominant form used today is gauze impregnated with these agents, which allows for rapid and precise application through wound packing.
And there's an important historical note here about the danger of older formats.
Yes, earlier versions came in powder form. While sometimes effective, the sources caution that powder forms carry a significant complication risk.
Like what?
including the potential for introducing air emboli or foreign material into the open vasculature, or causing complications later by leaving non-dissolvable powder fragments deep within the tissue.
So gauze is the standard.
The standard practice now is to use impregnated gauze, which is less likely to carry these systemic risks. Proper wound packing is essential here. It involves stuffing the entire wound cavity firmly to absorb liquid, concentrate factors, and apply direct pressure from the inside out.
We must also talk about the less obvious intervention, the role of splints in hemorrhage control. How does just immobilizing a fracture actually stop bleeding?
It's often overlooked, but stabilizing fractures is paramount for hemorrhage control, especially in long bone and pelvic injuries. The reason is twofold. Okay. First, broken bones, particularly sharp fragments of a fractured femur or tibia, are prone to lacerating adjacent blood vessels and tearing muscle tissue, which causes ongoing concealed bleeding.
And
Second, movement of a fracture site actively disrupts and breaks up any partially formed clots, which just restarts the hemorrhage cycle. Therefore, immobilizing the fracture stabilizes the tissue and protects that nascent clot.
what are the primary types of splints and their specific uses in this context?
We utilize different tools for different goals. Air splints, which are inflatable vinyl cylinders, are excellent for stabilizing lower extremity fractures and simultaneously controlling hemorrhage associated with venous bleeding.
How does that work?
When inflated to around 50 millimeters of mercury, they act as a massive, uniform pressure dressing across the entire limb. But critically, that 50 millimeter Hg pressure is usually insufficient to occlude an arterial bleed.
So it's not a substitute for a tourniquet.
Not for arterial hemorrhage, no. We also use rigid splints to ensure stability and reduce the excruciating pain associated with fractured limbs, which also helps prevent the patient from moving and further protecting the clot.
And then there are traction splints, which are specifically for the femur, the largest bone in the body, which can hide the most internal blood loss.
Traction splints are designed specifically to stabilize mid-shaft femur fractures. The mechanism involves pulling traction to the ankle, while countertraction is applied via straps to the ischium and groin.
And that pull realigns the bone.
This slight pulling reduces the spasm of the thigh muscles and prevents the jagged bone ends from overriding and grinding together, which stops them from tearing more tissue and breaking up clots. For any splint application, continuous monitoring of distal circulation is mandatory
To make sure you haven't cut off blood flow yourself.
to ensure the splint itself hasn't compromised blood flow to the limb.
Before we move on to internal management, there's one fascinating and critical protocol regarding head trauma, bleeding from the nose or ears.
This is a textbook critical distinction. Bleeding, or the leakage of clear fluid from the nose or ears after a significant head injury, often indicates a basal skull fracture, a fracture at the base of the skull.
And the protocol is very specific.
The absolutely crucial protocol here is, do not attempt to stop or block the flow. The responder must only cover the site loosely with sterile gauze and apply very light compression.
Why is blocking that flow so dangerous?
You might be blocking the drainage of blood or, even worse, cerebrospinal fluid CSF.
The fluid that bathes the brain.
Exactly, the fluid that bathes the brain and spinal cord. If the flow of CSF is blocked, the pressure inside the skull intracranial pressure, or ICP, can rise dramatically, leading to potentially devastating brain compression and herniation. You have to allow that pressure to relieve itself naturally.
And here's that fascinating nugget of knowledge we promised. How do clinicians confirm if that clear fluid is actually CSF?
Well, if the fluid is mixed with blood on the gauze, it might create what's called the halo sign or bullseye sign. The blood forms a central spot, and the clear CSF diffuses outwards, forming a lighter ring around it.
But for a more definitive answer,
For a more definitive answer, a fascinating piece of field technology comes into play. You can actually test the fluid with a standard glucometer,
a blood sugar monitor.
a blood sugar monitor. CSF contains glucose, whereas the watery component of nasal mucus or tears does not contain high glucose levels. A high glucose reading on the fluid strongly confirms a serious breach of the cranial cavity. That's a piece of knowledge only a seasoned clinician might immediately recall.
That detail really highlights the sophistication required in pre-hospital assessment. But as we established, managing internal hemorrhage means the definitive fix isn't in the field, it's on the operating table.
That is the ultimate constraint. Internal bleeding, whether from a ruptured organ or a fractured pelvis, requires surgery to physically clamp or repair the vessel.
So the pre-hospital goal is just to stabilize and run.
The goal of pre-hospital management is simple. Aggressively treat the resulting shock. minimize movement of the injured parts, and ensure the fastest possible rapid transport to a facility capable of surgical intervention and massive blood transfusion.
And this need for speed has been revolutionized by technology in the hospital too, right?
Absolutely. The use of immediate bedside ultrasonography, often referred to as a fast exam-focused assessment with sonography for trauma, has become standard. It allows trauma teams to quickly identify free fluid, which is blood, in the abdomen or chest cavity before they even take the patient to the OR.
Speeding up the decision for surgery.
It speeds up the decision for immediate surgery and directs the surgical approach.
When we talk about treating hemorrhagic shock, we are talking about fluid resuscitation. This protocol must be executed quickly, but with immense precision. What are the key instructions for stabilizing the patient?
The initial steps are straightforward but non-negotiable. Comfort the patient, keep him warm, keep them supine, and give them nothing by mouth.
Why nothing by mouth?
The gastrointestinal tract must be empty in case immediate anesthesia is required for surgery.
And 5 access is paramount, but in a crashing patient, the vessel might be collapsed.
That's a real problem. We aim to establish venous access using an 18-gauge 5V catheter, or preferably 2 large bore lines, using an over-the-needle catheter. The large diameter allows for rapid infusion of fluids.
And if you can't get a vein?
If peripheral access is impossible due to severe shock, modern protocols authorize using an intraosseous line, an IO line.
A needle into the bone.
Inserting a needle directly into the bone marrow cavity, which provides a non-collapsible route for fluids and medications.
Let's discuss the critical concept of fluid administration. The old approach was often to fill the tank as fast as possible with crystalloids until the blood pressure normalized. That's been debunked, hasn't it?
It has, completely. That approach was found to disrupt the fragile clots that were forming and contribute to the lethal components of the trauma triad.
So what's the new philosophy?
The modern philosophy is permissive hypotension, or damage control resuscitation. The goal is not to return the blood pressure to a normal 12/80. What is the goal then? It's to maintain the systolic blood pressure in a low normal range, often targeted around 80 or 90 millimeter Hg, just enough pressure to perfuse the brain and heart, but not so high that it blows out the fragile clots and accelerates the hemorrhage.
So we're stabilizing the patient gently, not aggressively. And what specific fluids are we using?
We use isotonic crystalloids, like normal saline or a lactated Ringer solution. The protocol is to administer an initial fluid bolus, often 250 millimol, and then repeat in 250 milliliter increments, only to maintain that target low normal blood pressure.
And it has to be done on the move.
This fluid administration is crucial, but it must be done without delaying transport. And critically, the source material emphasizes: always use warm piety fluids.
Back to the trauma triad.
Hypothermia is half the battle. Every intervention must fight the trauma triad, not contribute to it.
And this brings us to the most significant shift in resuscitation, moving beyond just saline. Crystalloids, while necessary to fill the physical space, don't replace oxygen carrying capacity or clotting factors.
Exactly. And this is where the concept of the massive transfusion protocol, or MTP, comes into play. It's a critical element of modern trauma care that our sources stress. Crystalloids dilute the remaining blood components, worsening the coagulopathy and the acidosis.
So the key is to start blood products early.
In cases of suspected severe hemorrhage, you have to start blood products early.
What does that mean practically? What is modern blood replacement trying to achieve?
Modern NTPs attempt to mimic whole blood replacement, often aiming for a 1-to-1-to-1 ratio.
And that's 1 unit of?
1 unit of packed red blood cells, 1 unit of fresh frozen plasma, and 1 unit of platelets.
So each one does a different job.
Right. RBCs restore oxygen carrying capacity. FFP replaces the essential clotting factors like fibrinogen, and platelets provide the initial plug component we talked about earlier.
I see. So you are simultaneously fighting all 3 components of the trauma triad. You replace the volume, you replace the clotting factors to fight coagulopathy, and you warm the products to fight hypothermia.
It's a synchronized multi-pronged attack. The old way of only giving RBCs meant the patient received volume but had severely diluted clotting factors, which practically guaranteed coagulopathy.
So the 1.1.1 approach.
The 1.11 approach recognizes that blood loss is a complex biochemical catastrophe, not just a plumbing problem. This is the only way to effectively reverse that spiral.
As we synthesize this section, let's go over the final checklist for the management of hemorrhagic shock. The culmination of all these priorities focused on stabilization and rapid evacuation.
This list is the final operational flow for the care team. First, immediately take standard precautions and address the primary killer. Stop severe external hemorrhage using pressure, hemostatic agents, or a tourniquet.
Then the airway.
Second, manage the airway.
Yeah.
Establish and maintain an open airway, ensuring that powerful suction is immediately at hand to manage any potential vomiting or secretions.
And the patient's psychological state and position.
Comfort and calm. The patient reassurance is a form of pain management, and keep them strictly in the supine position, flat on their back, to maximize cerebral perfusion and ensure they receive nothing by mouth.
And immobilization.
Third, immobilization is key. Splint the patient onto a backboard if the MOI dictates spinal precautions, and individually splint any extremity fractures en route to the hospital to prevent further bleeding.
And the ongoing continuous management.
Insert those 2 large-bore 5E lines, administer warm isotonic fluids in cautious increments to maintain that permissive hypotensive goal, and continually monitor serial vital signs.
What are you watching for?
This must include ECG monitoring for dysrhythmias, as acidosis affects heart rhythm, and continuous assessment of level of consciousness, pulse, and blood pressure. Every second counts, and the goal is to hand off a living, stabilized patient to the surgical team.
This entire deep dive has been a testament to the brutal speed of physiological failure. We've gone from the core trauma protocol, shift moving from ABC to CAB, because circulation, the delivery system, is the absolute limiting factor in survivability.
We've established that critical threshold of 20% volume loss, the sophisticated dance of hemostasis, and the insidious nature of internal bleeding, where signs like tachycardia and pallor are the only immediate clues you have before the system collapses.
And most powerfully, we've analyzed the trauma triad of death, that deadly, self-perpetuating spiral of hypothermia, coagulopathy, and acidosis, which requires aggressive, comprehensive intervention.
Including the early and proportionate administration of blood products under a massive transfusion protocol to break the cycle.
Our key takeaway for you, the learner, centers on early recognition and immediate action. Any patient presenting with tachycardia and pallor following a significant mechanism of injury must be presumed to be in shock.
And for external hemorrhage, that 20-second window for effective tourniquet application on an extremity is the difference between buying time and losing the patient before they even reach the definitive care of the operating room.
The knowledge of permissive hypotension and the superiority of blood product replacement over crystalloids is the strategic understanding that defines modern survival rates. Immediate mechanical control of external bleeding coupled with rapid, targeted internal stabilization is the only formula that prevents the patient from progressing past compensated shock.
And that leads us to a final provocative thought to consider. Building on everything we've discussed, we focused heavily on immediate pre-hospital stabilization, which is often accomplished by highly trained teams in minutes.
But for internal bleeding, definitive care always requires an operating room.
And the complex logistics of a massive transfusion protocol.
Given that survival rates plummet based on time to surgery, what are the broader logistical implications for healthcare systems and resource distribution, especially in rural or remote areas?
Right. If the patient is 2 hours away from a level I trauma center, the pre-hospital stabilization efforts, no matter how perfect, may only delay the inevitable.
The clock is counting down to the onset of irreversible shock, and the geographical distance to the surgeon and the blood bank unexpectedly accelerates that process.
It raises a critical question about resource allocation. How many minutes does perfect field management truly buy when the patient is hundreds of miles from the single resource that can actually stop the bleeding? It's a factor that challenges our entire model of trauma system design.